And for the remainder of this time slot, I'm going to defer to my colleague, Dr. Karen Van Oudegem, to provide a much more entertaining talk about Andre at home and studies that we found so far. Yeah, so Karen is an Andre affiliated scientist and currently holds a research appointment in the Department of Kinesiology at the University of Waterloo, where she's been working to help advance remote monitoring platform within Andre. She completed her doctorate in kinesiology at the University of Waterloo and a postdoctoral fellowship at the Toronto Rehabilitation Institute. The goal of her research is to apply her expertise in the area of balance and mobility assessment to the application of health technologies for older adults and individuals with neurodegenerative disease. So the question was, why is it important to track these with wearables? Doesn't the patient communicate this at their appointments, or are they unaware and the wearables identify undiagnosed risks? I don't know if you want to take this, Karen, or if you want me to answer it, but.
No, go ahead, Ben.
I think that the goal of utilizing wearables to provide more accurate and quantitative data throughout a continuous framework. So creating kind of this movie of symptoms and how they fluctuate over time for clinicians compared to brief snapshots and relying on self-reporting for symptoms and characteristics of disease. I'm sure people might want to add to that, but that would be my response.
Thanks, Ben. And just confirming that you see my slides.
Just, can you hear me?
Yep.
Just to add to Ben, and I guess specifically for Hugh and for everybody else, I think one of the things, I hope that this will be addressed a little bit more broadly when you see what's being proposed in the Hands Ontario sub-studies. Will give you a sense of some of the unique measures and targets and questions that we're trying to ask. So we'll maybe get back to that question if it hasn't been more fully addressed a little bit later this morning.
Thanks, Rick. Okay, so I'm here today to speak about some of Andre's work to date in the remote monitoring space, and specifically our work with wearables. So thanks, Ben, for that really appropriate introduction to the data that I'm about to share. I'm really representing the collective effort of many people who are working under the Andre umbrella. And as we look forward, working to integrate some of what we've learned from our work to date into Hands Ontario. Okay. So over the course of the next 15 minutes or so, I'll provide a bit of background to the work that has been happening within Andre in order to help us establish a remote monitoring platform of research, followed by a walkthrough of some of the pilot work that we've been doing, and then finally wrap up by just sort of describing how this work has informed next steps. So there's good evidence of the links between health status and the kinds of measures that we can capture at home. And in the examples that I've listed here related to dementia risk, you can see the value of perhaps understanding sleep and gait or walking due to its association with increased risk in older adults. So this risk linked to poor sleeping or poor quality gait, as well as the added value of understanding physical exercise or social engagement due to the reduction in risk of dementia. So all of these behaviors we can capture at home, and we can see that there's an importance in terms of their link to our health. Further, some key measures related to neurodegenerative disease are difficult to capture successfully in the clinic, either because they occur infrequently, like a fall event, or because they vary over time, like a person's mood or their social engagement or periods of stress, or they're difficult to replicate in a clinic setting, perhaps a symptom such as agitation or freezing of gait, as can occur in people living with Parkinson's disease. Insights into these kinds of behaviors often rely on self-report, and I think this is getting a bit to the conversation or the response that Ben gave to Hugh's question. And sometimes this self-report can be problematic. But one must ask, just because we can measure them, should we measure them? And in answer to that, I will give a resounding yes. Monitoring these key markers or these key behaviors at home has the potential to do many things. It has the potential to provide a more rapid response that can invoke action by giving feedback to the individual, to the care provider. And of course, this is dependent on the time course of the feedback, as Ben alluded to earlier. And we hope to tighten that time course so that the feedback can be more immediate. And later this morning, you'll hear a really good example of this possibility from Dr. Sonam Dubey. Also, monitoring key markers has the potential to reveal triggers to infrequent events. So, for example, what was occurring prior to a fall, and insight into time-varying changes in symptoms. So, an example there might be the ebb and flow of Parkinsonian symptoms throughout the course of the day, for example. Monitoring these markers has the potential to provide a more sensitive method to evaluate treatments, because we're no longer limited to evaluation at discrete time points over the course of the treatment, and also to improve access for those underserved by clinical services, such as those individuals living in rural or remote areas, all of us living during pandemic times, or instances where people don't have access to specialist care. So there's a lot on this slide, I know, and I'm not going to linger here, but I simply included it to illustrate that the first step for us in developing this remote monitoring platform was to come up with a working model. And we wanted it to consider all of the necessary elements for an innovative approach to remote monitoring. So all of the stuff that you see on the left-hand side, which forced us to sort of develop an idea and some thoughts around what kind of data we want to capture, how we want to capture it, and on what time scale. And also sort of exploiting all of the strengths and existing infrastructure within Andri, including this expansive network of clinicians and researchers and persons with lived experience, advisory groups, and the really rigorous and robust approach to data management. So this became sort of our working model by which we sort of have moved forward. And so in order to put the plan into action, we established this very practical set of goals. Really, the goal is for no one to end up looking like the person in the top right-hand corner of this slide. But practically, we set out to identify the best technology or combination of technologies that meet our needs, and where there are barriers, to remove those barriers to use. Make the most of the information we get by optimizing how we manage it. So there is a large volume of data that comes off these sensors, and it's really important that we find the best way to manage that data, and also to develop new ways to look at it. And finally, sort of in light of our focus on this research care partnership, find the best way to communicate the information to people who would benefit, whether that be individuals, caregivers, or healthcare providers. And to that end, we've been guided by some basic principles. We want the information that we capture to meet the needs of users and care providers. And by that, we mean it needs to be easy to use, we need to limit burden, and we must provide meaningful information to individuals and care providers that can impact self-management of health or symptoms of disease. We want to be able to provide information that's important to healthcare decision-making, so we want to have impact on clinical care, and we want to contribute to science. We want to help to advance new understanding and new tools in this field. In order to achieve this, we need the tools and methods that we develop and use to be usable. And by that, I mean really usable, not just claim to be usable, but be usable for our populations of interest in a way that allows us to get the information that we desire. Be personalized, acknowledging that everyone has an individual health profile, and we need to address the sort of that heterogeneity across people. And be validated, and by that I mean proven to do what those tools and methods are supposed to do and for the purpose in which it was intended. So getting back to this fit for purpose idea that Ben referred to earlier. In support of sort of keeping us on track to achieve those goals and to be guided by those principles, we solicit feedback both formally and informally on an ongoing basis. I've included some examples here just to sort of illustrate the kind of feedback that we get. In the chart on the right, we categorized responses to a survey based on health areas of interest. And in this particular case, we were interested to know how many health interests that were identified were currently being addressed by our approach. And that was 44% of the interest areas that were identified. But there's this large proportion of other areas of interest that we are working toward being able to address. And that includes things like mental health and wellness. So health measures that focus on anxiety or mood as examples, additional physiological domains such as ventilation, and other health and lifestyle related events like a fall, as I've mentioned before. In the table on the left-hand side, you can see that the responses in terms of the behaviors of interest vary based on what people intend to do with the information. So do they want the information in order to help them manage their neurodegenerative disease versus do they want the information to be able to communicate more fully or describe what they're experiencing to their healthcare provider. So you can see here that there are different responses based on the intended target of the information. And I've also included here a quote that we received from someone who was involved in our REMIND study, which I will talk about shortly. So this was a care partner to a participant in REMIND. And I'm including it here because I think it really exemplifies the potential for impact on a really personal level of this remote monitoring approach. So this person says, living as a caregiver 24/7, each small change in your loved one becomes the new normal. You can easily miss the more day-to-day changes as you are looking for the big changes that you can report to the neurologist at your scheduled appointment once every 6 months. So I think we can't underestimate the value in obtaining these kinds of behaviors, both for the individual who's perhaps living with the neurodegenerative disease, but also for the people within their circle of care. So to date, we have conducted 3 primary studies involving wearable technology. Across all the studies, participants wore multiple sensors. So if I take you back very briefly to that sort of working model, when we were trying to imagine what kinds of data we wanted to collect and how we wanted to collect it, we really felt that part of the innovation and the opportunity here was to take a multi-dimensional approach, and Rick alluded to this too, to understanding these behaviors. And from our perspective, that would and possibly would require multiple sensors. So across all of these studies, participants wore multiple sensors, various numbers of multiple sensors over a 7-day period in their natural settings. And so we refer to this as during free living conditions. In our earliest pilot, the study that I've sort of provided an overview on in the left-hand panel, we recruited participants, older adults who were living in the community. They were equipped with as many as 4 sensors for this study duration. And at the end of it, they answered questions about their experience. Then we launched the REMIND study, and REMIND stands for Remote Monitoring of Health Status in Neurodegenerative Disease. And here we really wanted to dive in and answer the question about the feasibility, or how acceptable and tolerated would wearable sensors be amongst people living with neurodegenerative disease. So in this particular study, we had a few more sensors. In the first study, in the older adult study, there were many sensors, but they were all of the same type. So they were all accelerometers, which Ben described earlier. In the REMIND study, we had multiple accelerometers, but we also had different sensor types. And in this case, we included a continuous ECG monitor, so we could measure heart function over the period of the study collection. So in this study, we adopted what we refer to as, I guess, a hybrid model, where participants came into the clinic. They had a baseline clinic visit, so we have sort of a rich data set of clinic data, and that was coupled with this free living data. And in this study, care partners were co-enrolled. And at the end of the study, we had both the participants and the care partners answer questions about their experience with the sensors. And finally, we sort of contributed our wearables sort of platform and our expertise to a study that's being conducted by Dr. Lorraine Kalia at Toronto Western Hospital, where she is looking to sort of explore the feasibility and the utility of using wearable technology to evaluate the effectiveness of a dance intervention. So in this case, for participants who are enrolled in the Dancing with Parkinson's program. So in that particular study, we reduced the number of sensors again. It was more likened to the very early pilot, but we had two 7-day wearing periods, one prior to the dance intervention and then one immediately following the dance intervention. So the sensors to date that we've used, Ben, again, this is sort of a reflection on an earlier slide that Ben showed, where we primarily relied on accelerometry placed in different locations on the body, including one in a subset of participants mounted sort of at the throat level, which was used to monitor speech using the same sensor technology. And then, as I mentioned, the portable ECG in the case of the REMIND study. So across all of these studies, we had some similar and overlapping goals, and those were to evaluate the acceptability of a multi-sensor extended wear, so more than just a few hours, extended wear approach to remote patient monitoring, to find the minimum number of devices needed to capture what we consider to be essential health outcomes. And so in the case of the REMIND study, we had people wear more than we knew was likely to be necessary, but we did that very purposefully so that we could reduce that data and those number of sensors down to sort of a minimum sensor set. So we needed to confirm what that minimum sensor set was. We wanted to be able to confirm existing methods and develop new methods for analyzing the wearables data. And we wanted to be able to come out at the end of this with sort of a process inclusive of really careful methods for storing, managing, processing, and then presenting these large volumes of information. So what have we learned so far? I'm just, with the time I have left, going to focus on a few of the highlights, namely that I think we're very confident at this point that a multi-sensor extended wear approach is acceptable to both older adults and people living with neurodegenerative disease. And also that multiple sensors provide important and complementary information that we need to be able to interpret daily behavior. That there is need for new ways to analyze the data. So I'll talk a bit more about that just in brief in a subsequent slide. And that we can indeed translate this data, this massive volume of data, into interpretable outcomes for participants. So in follow-up to sort of our number one highlight, this finding that we can in fact use this approach successfully in our cohorts of interest. Very broadly speaking, we learned that a multi-sensor 7-day approach is feasible because nobody dropped out of the studies. There were no adverse events. The devices were relatively robust, meaning that almost all of them, with the exception of perhaps 1 or 2, came back unbroken and with the data that we expected. So the volume of data that we expected. But in addition to that, the interviews that we held at the end of the studies provided much more insight into matters of importance, namely that comfort is really the most critical factor. Many participants made comment that this wouldn't be possible if the sensors weren't as comfortable to wear as they were. And other factors included the ease of taking them off and on, and also some reports of skin reaction to extended wear. Participants did distinguish between their experience with the different sensors, so sensors mounted on the wrist, for example, versus the leg. And these differences were driven primarily by the degree to which they interfered with activities of daily living. In our case, with the technology that we've used to date, they cannot be submerged in water. And so we did have to have participants remove them when they were showering or bathing or swimming. And this caused some concern for the participants. They were concerned about the sensors getting wet. And lastly, they generally would have preferred the devices to be smaller and slimmer, but reported that they were quite okay for the study purpose. So all of these things will feed into our refinement and some of the differences that we intend to make as we move forward with integration into HANDS Ontario. We also wanted to be able to quantify tolerance or feasibility with a measure that we could report in addition to the results of these interviews. And so we looked to using something called non-wear as this measure. And so here are sort of a version of the squiggly lines that Ben showed before. And non-wear is actually quite easy to extract from these data because there are periods of time where the sensor isn't moving. And it's important that we identify these because we don't want to misidentify them as times when people are being sedentary or sleeping. So we needed to do this anyway, and it became a really valuable measure for determining just how much of the study period people were wearing their sensors. And so here, just very briefly, I've got bolded here across all the studies. People wore the sensors for a large proportion of the study period. So we took the period of time that they weren't wearing the sensors and we kind of removed that. And what we were left with was the percentage of time that people were wearing the sensors. And in all cases, it was above 80% of the 7-day wear period, and in more commonly above 90%. So we were very pleased to see this. And just to sort of highlight why this is important and under what circumstances coming to understand this has been incredibly helpful is as it relates to time of day. So to the 2 panels that you see on your left-hand side, what those bars are showing is the proportion of the study period when people were wearing the sensors. And on this, in these 2 panels, this is multi-sensor wear because of course that is our interest. That was our question of interest. And we defined that for the purposes of the REMIND study, and that's what this data reflects, to be when people were wearing 3 or more sensors at a time. And so we were curious to know if there would be differences in day versus night. It was not the case, very high compliance rate. We do see here a slight drop off. In this particular plot, we're looking at each day of the collection period, and there is a bit of a drop off at the end, but still above 90%. And then in the panels on the right, these are data from the Dancing with Parkinson's study. And again, it's the same measure. So we're looking at the proportion of the study period, all very high. What you see in the purple bars are how much of the time people wore them for the first time, so before the intervention, and then when we asked them to wear it again a second time, so that information is in the blue bars. And so for the most part, each of those sets of blue bars, which represents a different participant, those numbers are not of importance here, just to know that they're each a different person. For the most part, there wasn't a lot of difference between their willingness to wear the sensors the first time versus wearing them again. And this is important for us to understand, because we do want to be able to use these technologies and this approach, for example, to monitor change over time, or in this case, to monitor the effectiveness of an intervention. Okay, so this is probably going to scare a few people, but I will try to walk you through it. The second highlight that I wanted to share today was the finding that multiple sensors really do provide important and complementary information. So if we look at this rather uninterpretable plot, I'll just to orient you to it, each line of data, so each line of green squiggly data is a day, so a 24-hour period. This is for one person. And as you work your way up from the bottom to the top, you have day 2 and day 3 and day 4. And on the far left would be midnight. And again, on the far right with noon denoted by that blue line right down the middle. And these green squiggly lines represent activity. So Ben had talked about activity previously. So taken off of the wrist sensor. So we can sort of take a look at this. If we had a single sensor model where we only had a sensor on the wrist, we would be able to capture some information about activity. The height of that squiggly line tells us how intense the activity was. So we could get a bit of information about how people are going through their day. We could look across days and understand if there's a pattern that's emerging there about just how active they are and at what times of day. Still, using data from that wrist sensor, we could then layer on top of this information some added detail, in this case, detail about a person's sleep. So these red and orange traces that I've just layered on top here indicate sleep. So when the mark is high, they're sleeping. When it drops, they're awake, and or they've had a disruption to their sleep. And then back up again for another period of sleep, and back down if there's been an awakening. And so just to orient you to that kind of data. So you can see sort of from midnight to 6 a.m. they're sleeping, and then again sort of near 10 or 11 p.m. they're back to sleeping. But we see that there's some disruption to the sleep. And we see that there's a little bit of activity that's happening within that sleep time, which might be the cause of the disruption, but we don't know what's happening yet with any great detail. So now I've added information from the ankle sensor, and the white information that I've added to this bar is about walking. So every time you see sort of a rectangle or an added sort of bar in white, that's a period of walking. So now all of a sudden we can see that during that sleep period, some of the cause of that activity was actually that they got out of bed and they were walking around. And without understanding the gait or the walking, which we were able to capture off of the ankle, the story wouldn't be so clear. And there are instances here where what happens at the wrist maps on very nicely to what happens at the ankle, but there are other instances where that's not the case. So we see that these two dissociate. And that could be because they're doing an upper body activity, or it could be because the wrist isn't doing well to capture gait for a particular person. So this is just to highlight the value of multiple sensors. The third sort of finding or highlight that I'm going to share today is that there really is need for new ways to analyze the data for our cohorts of interest. So this includes instances in which existing methods, so algorithms or calculations that have been published in the literature, just need a little bit of refining or tweaking to apply to our populations of interest or to our situation of interest. But it also means taking advantage, again, of this volume and richness of data that is available to us. And so to that end, I'm going to overwhelm you with a little bit more squiggly line. And so here, this is all of the people who participated in Remind. And you see that they're color-coded by the disease cohort that they were a part of. So ADMCI, working from the bottom up, ALS, Parkinson's disease, sorry, I should say CVD for cerebral vascular disease, and frontotemporal dementia. And if we just sort of take an overview look at this, so now each column, so each set of data, which is divided by a blue line, is a day. And we can note that there's sort of an overall pattern with an ebb and flow, where there's more walking during daytime hours and less walking during nighttime hours. And we can also note that the differences that emerge within an individual over many days. Differences that emerge between individuals who were grouped together by disease cohort, and then of course across disease cohorts. So we continue to work to find ways to sort of package this data so that we can link it to health outcomes, so that we can provide feedback in order to help individuals with self-management and for other reasons, to monitor over time, for example. So so this is just sort of an overview, but what becomes really interesting from here is that we can then go down to individual participants. So to utterly confuse you, I've now switched things back again, where over here we've got days and rows, just like the first time you saw this data. There's sleep here, there's gait in white, and then there's activity in green. And what we could see in this first individual is that in many mornings, so this would be before 6 a.m., before that first vertical line, there's a lot of walking that's happening here. And it's resulting in the need on many days, possibly, to return to bed for another period of sleep. We can also see that this person completes several short bouts of walking each day. And overall, you know, there's a lot of activity that we're seeing day over day in this person. And this sort of provides a profile of this individual. This is in contrast to this person here, who shows an absence of activity as measured by the green bar, but lots and lots of short bouts of walking. So we know they're short because those bars are very skinny, those white bars. So short bouts of walking, but lots of them. And this is just to highlight here two things. One, that it's not just about the volume of walking in this case, but it sort of emphasizes the need to understand also the quality of that walking, which we can do with this kind of data. The other thing that's sort of interesting to note here is that, again, if we were only to have a wrist sensor worn by this participant, it's likely that we may have missed a lot of this walking activity. This particular example is a person living with Parkinson's disease. It's possible in this case that there's reduced arm swing, which is sort of a common feature of people living with Parkinson's disease. So in that case, you could see that, you know, trying to derive walking from an arm that isn't swinging would be difficult to achieve. So again, just to emphasize the value of having that multiple sensor approach. So I'm going to just speed this up a bit because I'm sure that I'm over time, but this is sort of a roadmap for us of all of the outcomes that we're sort of interested to explore or have already validated. So the box in blue are things that are very well validated from the literature and from work that we've done. In the yellow box in the middle, things that we're currently working on. Either to refine existing algorithms or to develop new ones, many of which rely on a multi-sensor approach. And what we sort of refer to on the far right and moving toward the far right as sort of our discovery outcomes. So things that aren't highly reported in the literature, but we know to be important and sort of where we hope to advance the space. So the last one, very quickly, the highlight that data can be translated into interpretable outcomes for participants. Critical to this success is that the data be meaningful for the people that are intended to receive it. And that means really understanding the what, the who, the how, and the when of the provision of this data. And to that end, in the REMIND study, we were guided to a version of a participant feedback form with sort of an iterative and multiple meeting approach with the Andre PCAC, or the Patient and Community Advisory Committee, who provided guidance to us in order for us to achieve this goal. And more specifically, really important insight into what we should include, how to simplify the visuals, how to orient people to the data, where to direct people to for additional information. So their involvement in this exercise was absolutely critical. So I'll just finish with this. We've learned a lot over the last year and a half or 2 years, and the studies that we've conducted. We've confirmed the feasibility of the approach, and we have a lot of information that will help us to refine that approach as we move forward into Hands Ontario. It's guided us to what we believe the optimal number of sensors are to capture the information that we're interested in capturing. And it's provided us with the data sets that we've needed to validate existing methods and to develop some new ones, and also to develop this process to manage the data, which we can now use for data that's coming in from Hands Ontario. So it's been a very rich set of studies and a series of data collections, all sort of helping to contribute to this future Hands Ontario initiative. And I will leave it there.